Hello students, today we are discussing about conduct disorder, which is a very prominent disorder in children and adolescents. We have come across number of behavioral problems which exist among children and adolescents. One such prominent behavioral problem is conduct disorder. It is a psychiatric syndrome characterized by a long standing pattern of violation of rules and antisocial behavior. This behavior or disorder generally occurs in childhood and adolescence, but the incidence increases from childhood to adolescence. How do we define this conduct disorder in a scientific way? According to American Academy of Child and Adolescent Psychiatry, conduct disorder is a complicated group of behavioral and emotional problems in youngsters. Children and adolescents with this disorder have great difficulty in following rules and behaving in a socially acceptable way. They are often viewed by other children, adults and social agencies as bad or delinquent rather than mentally ill. What are the causes? Why do they develop this kind of conduct disorder? The etiology includes a number of factors. It involves, that is, the etiology of conduct disorder involves an interaction of genetic or constitutional, familial and social factors. Children who have conduct disorder may inherit decreased baseline autonomic nervous system activity requiring greater stimulation to achieve optimal arousal. This hereditary factor may account for the high level of sensation seeking associated with conduct disorder. There are potential causes for the occurrence of this disorder. These causes include early maternal rejection. If a child is not adequately taken care by the mother, this rejection from the mother may lead to this kind of a behavioral problem in the children. Separation from parents without an adequate alternative. Some reason, if the parents are away from the child and if there is no substitute in the place of the parents, naturally the child may develop this kind of a disorder. Sometimes it could be a caregiver or early institutionalization. It could be a child leading a life in the orphanage or in any other center other than with the parents. Family neglect, abuse or violence, parental mental illness, sometimes parental marital discord are also the reasons for the development of this conduct disorder in children. Apart from all this, the other significant causes are genetic defects and sometimes the poverty, which may lead to the development of this behavioral problem. When we say the role of the caregiver in the development of this behavioral problem, exposure to the antisocial behavior of a caregiver is particularly an important risk factor. Children with conduct disorder may be present in all economic levels, but appear to be overrepresented in lower socio-economic groups. Most of them, they are from the lower socio-economic group, that is the indication of the present day research on conduct disorders. Another common feature appears to be inconsistent parental availability and discipline. In most of the families, there is inconsistent discipline between the parents, and sometimes accessibility to the parents is also very difficult. These situations may lead to the development of this disorder. Because of all these factors, children with conduct disorder do not experience a consistent relationship between their behavior and its consequences. If there is inconsistency in the discipline, naturally the children cannot understand for which behavior the punishment is given, when it is given, why sometimes no punishment is given for their behavior. So, this kind of a confusion may also be one of the reasons for the development of this conduct disorder. Once we have understood the causes of the conduct disorder, what are the signs and symptoms of the development of this behavioral problem? There are specific symptoms for the diagnosis of this conduct disorder. The presence of these symptoms may help us to identify or to know that there is some deviation in the child's behavior and it is not a normal developmental pattern. So, what are those symptoms? Conduct disorder is characterized by a repetitive and persistent pattern of behavior in which the basic rights of others or major age appropriate societal norms or rules are violated. According to the DSM-4 TR, symptoms typically include 3 of the following criteria in the past 12 months with at least one criterion present in the past 6 months. So, this condition has to be fulfilled in trying to diagnose a child as suffering with the conduct disorder. The symptoms include aggression to people and animals. Most of the children who are having this kind of a conduct disorder often bullies, threatens or intimidates other people. They also initiate physical fights. They might have used a weapon that can cause serious physical harm to others. The weapon could be a bat, a brick, broken bottle, knife and gun. Has been physically cruel to people and animals. Has stolen while confronting a victim, for example, mugging, purse snatching, extortion. Has enforced someone into sexual activity. These are the symptoms of aggression towards the people and animals exhibited by the child who is suffering with this conduct disorder. Another symptom is destruction of property. The child who developed this conduct disorder might have deliberately engaged in fire setting with the intention of causing serious damage, or might have been deliberately destroyed others' property other than by fire setting. Another symptom associated with this conduct disorder is deceitfulness or theft. The child has broken into someone else's house or building or car. They often lie to obtain goods or favors or to avoid obligations. The child might have stolen items of non-trivial value without confronting a victim, for example, shoplifting, but without breaking and entering, forgery. These are like non-trivial value items without confronting a victim. They try to do these kind of the behaviors. Sometimes they may engage into the serious violation of rules. This is also one prominent symptom exhibited by the children who suffer with this conduct disorder. The serious violation of rules include the child often stays out at night despite parental prohibitions beginning before the age 13 years. The child might have run away from home overnight at least twice while living in parental or parental surrogate home, or once without returning for a lengthy period. The child is often truant from school beginning before the age 13 years. These are the main symptoms which are associated with conduct disorder. Apart from this, there might be some school related factors which are concerning the students with conduct disorder. These school related factors include low academic achievement from the outset of the school years. The present research also indicates the reading disabilities are also associated with the conduct disorder. One study found students with conduct disorder had a reading level 28 months behind their peers and typically 2 to 3 years behind their peers academically. Children who had conduct disorder also are found to have lower verbal skills. Not only the lower verbal skills, but they were also found to be low in abstract reasoning abilities. There are two subtypes of conduct disorder which are provided, or we can say which have been formulated based on the age at the onset of the disorder. One type is childhood onset type and the other is adolescent onset type. Both these types differ with regard to the characteristic nature of the presenting conduct problems, developmental course, prognosis and gender ratio. Both subtypes can occur in a mild, moderate or severe form. In assessing the age at onset, information should preferably be obtained from the youth and from caregivers. Because many of the behaviors may be concealed, caregivers may underreport symptoms and overestimate the age at onset. Now, let us see in detail what is this childhood onset type and adolescent onset type. Childhood onset type. This subtype is defined by the onset of at least one criterion characteristic of conduct disorder prior to age 10 years. Individuals with childhood onset type are usually male members who frequently display physical aggression towards others, have disturbed peer relationships and may have had oppositional defiant disorder during early childhood and usually have symptoms that meet full criteria for conduct disorder prior to puberty. These individuals are more likely to have persistent conduct disorder and to develop adult antisocial personality disorder than are those with adolescent onset type. Then, what are the characteristics of those children who are under the category of adolescent onset type? This subtype is also defined by the absence of any criteria characteristic of conduct disorder prior to age 10 years. Compared with those with the childhood onset type, these individuals are less likely to display aggressive behaviors and tend to have more normative peer relationships, although they often display conduct problems in the company of others. These individuals are less likely to have persistent conduct disorder or to develop antisocial personality disorder. The ratio of males to females with conduct disorder is lower for the adolescent onset type than for the childhood onset type. And both these disorders may range from mild to severe. When we speak about the severity of the disorder, we can categorize that the child is suffering with a mild conduct disorder if few of any conduct problems in excess of those required to make the diagnosis and conduct problems cause only minor harm to others. But a child can be labeled as suffering with moderate conduct disorder if there are number of conduct problems and effect on others intermediate between mild and severe. On the other hand, the child can be diagnosed as having severe conduct disorders if many conduct problems in excess of those required to make the diagnosis or conduct problems cause considerable harm to others. So, depending upon the intensity of the damage done to the others, we label them as mild, moderate or severe. Now, how to diagnose a child as suffering with the conduct disorder? Sometimes most of the behavioral problems might look as if they are part of the developmental pattern. So, to label or to classify or to identify that the child is suffering with a severe behavioral problem, we need to focus on the diagnosis that particular disorder. So, the diagnosis of conduct disorder includes that a child can be diagnosed with conduct disorder if he exhibits a callous disregard for others and a sustained patterns of behavior that fit into general categories, that is, aggression against people and animals, destruction of property, deceitfulness and theft, and serious violation of rules. Conduct disorder is diagnosed and also treated by number of social workers, school counselors, psychiatrists and psychologists. Genuine diagnosis may require psychiatric expertise to rule out such conditions as bipolar disorder or ADHD. A comprehensive evaluation of the child should ideally include interviews with the child and parents. A full social and medical history has to be considered. A cognitive evaluation and a psychiatric exam are essential components of the diagnosis. One or more clinical inventories or scales may be used to assess the child for conduct disorder. Some of these scales could be youth self-report, overt aggression scale, behavioral assessment system for children, child behavior checklist and diagnostic interview schedule for children. The tests can be verbal or written or sometimes both and are administered in both hospital and outpatient settings. Assessment and diagnosis of conduct disorder or any emotional or behavioral disorder of childhood should be done only by a mental health professional, preferably one who is trained in children's mental health. Any diagnosis must be made in consultation with the child's family. The consent of the family should be taken into consideration. The assessment process should include observation of the child, discussion with the child and family, the use of standardized instruments or structured diagnostic interviews and history taking, which includes a complete medical, family and social history. When assessing and diagnosing any childhood emotional or behavioral disorder, the mental health professional should consider the social and economic context in which a child's behavior occurs. We have to focus on the social and emotional factors. They are the vital factors or components which decide the diagnosis. Accurate assessment and appropriate individualized treatment will assure that all children are equipped to navigate the developmental milestones of childhood and adolescence and make a successful adaptation to adulthood. Treatment must be provided in the least restrictive setting possible. Suppose sometimes the people ask, are there any specific exams and tests? People may ask whether there are any specific exams and tests in the diagnosis of the conduct disorder. Practically speaking, there is no real test for diagnosing conduct disorder. The diagnosis is made when a child or adolescent has a history of conduct disorder behaviors. A physical examination and blood tests can help to rule out medical conditions that are similar to conduct disorder. Rarely, a brain scan may also help to rule out other disorders, but otherwise there are no specific exams and tests in the diagnosis of this disorder. Now, what is the differential diagnosis and comorbidity associated with conduct disorder? Children with conduct disorder, like any other disorder, may have a high risk of developing other adjustment problems. Specifically, risk factors associated with conduct disorder and the effects of conduct disorder's symptomatology on a child's psychosocial context have been linked to overlap with other psychological disorders. The differential diagnosis should include attention deficit, attention deficit hyperactivity disorder, oppositional defiant disorder, mood disorder which include major depression, dysthymia, bipolar disorders, substance abuse and intermittent explosive disorders. How to prevent the conduct disorder in children? Like for any other disorder, more than the treatment, we have to focus upon the prevention. In spite of the preventive measures, if the problem still occurs, then we have to focus upon the treatment. As with oppositional defiant disorder, some experts believe that a developmental sequence of experiences occurs in the development of conduct disorder. This sequence may start with ineffective parenting practices, followed by academic failure and poor peer interactions. These experiences then often lead to depressed mood and involvement in a deviant peer group. However, other experts believe that many factors like child abuse, genetic susceptibility, history of academic failure, brain damage or a traumatic experience influence the expression of conduct disorder. Early detection and intervention into negative family and social experiences may be helpful in disrupting the development of the sequence of experiences that lead to more disruptive and aggressive behaviors. Now, what is the treatment for the conduct disorder? Conduct disorder is difficult to overcome, but it is not hopeless. In situations where an effective support network of parental figures, teachers and peers can be assembled, the disorder is manageable. Treatment may include cognitive behavioral approaches, family therapy, peer group therapy and medication. If we focus on cognitive behavioral approaches, the goal of this particular therapy, that is cognitive behavioral therapy, is to improve upon problem solving skills, communication skills, impulse control and anger management skills. On the other hand, in family therapy, they focus on making changes within the family system, such as improving communication skills and family interactions. Sometimes we use peer group therapy in dealing with this disorder. This therapy is often focused on developing social skills and interpersonal skills. Not in all the cases, but in some cases medication is also used. Though it is not considered effective in treating conduct disorders, medication may be used if other symptoms or disorders are present and responsive to medication. All these strategies are used depending upon the necessity of that particular child. In some cases, all the strategies may be used. In other cases, whichever is more prominent, whichever is more effective, that is mostly considered in dealing with the situation. However, we can say a combination of all these approaches are a part of the treatment. Sometimes, in order to be having an effective treatment for this conduct disorder, it is necessary that we need to integrate all the environments, that is individual environment, school and family settings. Not only that, the treatment should also seek to address family conflicts such as marital discord or maternal depression. In this manner, a treatment would serve to address many of the possible triggers of conduct problems. Several treatments currently exist, the most effective of which is multi-systemic treatment. In short form, we call it as MST. Just to have an understanding of what is this MST, let us briefly see about the concept MST. MST is an intensive integrative treatment that emphasizes how an individual's conduct problems fit within a broader context. The individual is viewed functioning within a series of interconnected systems like home, school, neighborhood, etc., that reinforces their antisocial behavior. The whole environment in which the child is brought up, that is most important in focusing upon dealing with this disorder. We have to take care of the family members who are associated with the child, making them aware of what sort of family environments are contributing to this kind of a behavior. Similarly, talking to the teachers with their assistance and also making them aware of the child's personality, and even the neighborhood, talking to the people around in the surrounding the family, surrounding the home. We have to consider their views, probably assisting them in dealing with these children could be a more comprehensive treatment. MST seeks to break this connection through empowering the individual and family members. The success rate of MST among severely antisocial youths has been found to be superior to other office-based therapy approaches, because this MST is more like a practical oriented approach rather than the other traditional approaches where the setup is within the office system as such. Adolescents who have undergone this treatment show decreased levels of aggression and improved familial relations. MST has also been found to decrease long-term rates of crime. However, we can say MST has not yet been shown to differentiate between rates of improvement for those presenting a child onset path and those with an adolescent onset path. The perceived gains from this treatment may stem from the fact that adolescent onset of the disorder is typically associated with troubled teens befriending other troubled teens. MST may serve to deter these bonds and thus improve their prognosis. The child onset type has proved to be more impairing and resilient and thus may not respond as well. The outlook or the prognosis for this disorder includes that children who have severe or frequent symptoms tend to have the poorest outlook. Expectations are also worse for those who have other illnesses like mood and drug abuse disorders.